So if you look at the bottom of the spine, the sacrum is highlighted there, and that's the ilium. And the sacroiliac joint rests between the sacrum and the ilium. And as you can see, the spine is right on top of the sacrum, so all the forces and the load of the body that's going through the spine in turn transmits to the sacroiliac joint. And it's like a keystone of a bridge. And the anatomy, if you delve into the anatomy of the sacroiliac joint further, you'll see that there are really thick ligaments supporting the sacroiliac joint. And these ligaments further stabilize the joint itself. And when there's disruption of these ligaments, that's one of the reasons why people will have a little bit more motion than normal in this sacroiliac joint. And as you can see here, there are really thick ligaments that could cause these types of problems that we talked about. There's also a abundant innervation or nerve endings that go around and into the joint itself, or the capsule of the joint. So you can imagine why, if you have an inflammation in the joint, the surrounding tissues, once they're inflamed, can irritate those nerves and result in pain. The other thing that we see here is these nerves that cross over the sacroiliac joint ultimately will end up going partly down the leg, sometimes all the way down to the leg. So the common causes of sacroiliac joint dysfunction are typically degenerative processes. You know, as we age, as we have an aging population, in fact, the baby boomers are now just beginning to go into the Medicare and 60-plus age, was the onset of this pain. You can have a trauma, and the joint, as we talked about, or the capsule, the ligaments around the joint could be injured, and that could be the onset or the start of the pain. And there may be a history of that in a patient's history. Other causes that are less common is pregnancy. In fact, many women, as they're going through labor, their lumbar spine, let's say, so if you have fusion in this region, as we know, with any fusion, you're going to transmit some of the forces or some of the motion from the fused levels to the adjacent levels. And also can be due to injury, trauma, or repetitive trauma. The activities of daily living can be partly traumatic on our tissues. Like, for example, sitting down itself causes extra stress on the discs. And so what are the patients presenting to our offices with? Patients who have sacroiliitis. They come and tell us they have back pain. So low back pain is a common complaint in patients who have sacroiliitis. The other complaint is buttock pain. Most people who even have buttock pain, they don't come and tell us they have buttock pain. They say, I have hip pain. But when we ask them where is their hip pain, they actually point to their buttocks. So much like patients who have disc herniations or lumbar stenosis, which is a pinching or irritation of the nerve, who have buttock pain, sacroiliitis patients can also have buttock pain for the reasons we discussed earlier. Some patients may also have thigh pain, pain radiating down the leg, again for the reasons we discussed. Because so basically the sacroiliac joint, we have known in our literature, in orthopedic and spine surgery literature, that it exists. But until recently, we haven't had an easier way or less morbid way for us to treat the patients. What I mean by that is the surgery was worse than the problem. Because if you don't have the appropriate diagnosis, any treatment that you offer is going to miss the target of whatever that target is. And this is not unique in spine surgery. It's true in... How do we image or further study sacroiliitis? One of the challenges here with the problem of sacroiliitis is oftentimes we do not see a thing on the MRI or CT scan that jumps out at us and says, I have sacroiliitis. So the MRI findings and CT findings are not always conclusive. Number of patients who are left with no diagnosis, then we've got to make sure that their pain is not elicited by pressure over the sacroiliac joint. Most patients with sacroiliitis even come and tell us maneuvers that stress the sacroiliac joint to try to mimic what the patient does when they're moving around in their daily activities to see if that elicits the pain. Then we compare that to the other side, and it becomes very helpful if the other side is completely normal. In the sacroiliac joint, injection of numbing medication, and if that specific injection relieves the pain that the patient's suffering from, then that confirms our diagnosis. So what is the Fortin finger test, which I've been mentioning a couple of times? Basically, it's putting the finger right at the posterior superior iliac spine or right over the sacroiliac joint. That's where the point of pain is. Sometimes the patients don't have pain when I push on it, but they say this is exactly where the pain's coming from. On the affected side is oftentimes eliciting the pain. So that's another finding on patient questioning or in the exam room. And then you also ask if a patient has asymmetry, meaning that one side is painful or the other side is much less painful or not painful at all, which are shown here. I will not go into too much detail, but basically the distraction, compression test, Gaislin's, and Patrick's test all are trying to produce some motion in the sacroiliac joint, which should, in a patient with sacroiliitis, induce the pain. And that's what we're basically doing with these tests. The one that's most widely used is the Patrick's test, which is shown on the bottom here, where we have the patient bend their knee on the side where the sacroiliitis is and put their ankle right above the other side knee, or right above the knee. And if that injection of the numbing medication relieves the pain, that further confirms the diagnosis.